Ladies and gentlemen, at the outset, I would like to thank Dr. Shabir Chekani, Dr. Balakrishnan and other colleagues for inviting me to speak at this meeting. Please bear with us while we get this going, and I think technology comes with a price, and at times you are stumped, and now that we have Professor Mishra making a grand entry, so hopefully we'll sort this glitch in a moment.
So इंतजार की घड़ियां खत्म हुई, and sorry about this technical challenge. Over to you, Handa sir. Thank you.
All right, sorry about this, and I've been assigned the task of speaking on hand pain, and I have no disclosures pertaining to this talk. Now, hand is the preeminent part of the body and has evoked and provoked many reactions. As Aristotle famously said, this is the tool of tools. If you look at causes of hand pain, you have myriads of causes which could range from arthritis, soft tissue rheumatism, neurological causes like carpal tunnel syndrome, and then you have trauma, repetitive stress injury, fractures, and multiple other causes. But if you look at the clinical approach to hand pain, this is fairly simple. Three things go into the making of a diagnosis of hand pain, and it is the basic tenet that we follow day in and day out. Rheumatology, as I say, is high touch, not high tech. So history, patient anamnesis is extremely important. Then we have examination, and last but not the least, investigations, and this allows you to recognize patterns. And this is at the heart of clinical rheumatology, and pattern recognition for the uninitiated is something like looking at these striped animals, and you don't need to be a wildlife expert to know that one striped animal is a tiger and the other is a zebra. So much in the same way we recognize patterns, and hand pain is no different. Now if you look at the arthritides that account for hand pain, we have several arthritides that could cause hand pain. Topping the list, osteoarthritis, then we have rheumatoid arthritis, psoriatic arthritis, crystal arthritides, connective tissue diseases, and a few others, and each has a distinct pattern, which I'm sure is an iteration of well-known facts. Osteoarthritis, the bony swelling is unmistakable, and you have a predilection for the distal interphalangeal joints, the proximal interphalangeal joints, and you have characteristic X-ray changes. This phenotype defines nodular osteoarthritis of our hands, and this may be there with knee osteoarthritis or maybe without knee osteoarthritis. And we've heard a lot of talks about knee disability and the approach to knee pain. Hand osteoarthritis is perhaps the poor cousin of knee osteoarthritis, but the phenotype is very distinct. Then as a clinician, you learn to recognize the boggy versus bony swelling. And then occasionally you could have rheumatoid arthritis patients with nodular OA of the hands, and the two may coexist. And this is an example of the plump swelling that you get with rheumatoid arthritis. In contradistinction, you have the bony swelling of osteoarthritis. And the X-ray changes are also characteristic. This is one example of the so-called gullwing appearance in which you have erosions and you have subchondral sclerosis. And this is also very characteristic. Another favored site is the thumb, the first carpometacarpal joint, and if you are tuned to looking at X-rays of the hands, this is a clinical diagnosis for you. The second condition that is important when one talks about hand pain is rheumatoid arthritis, which in our practice is the commonest inflammatory polyarthritis that we come across. And this is a diagnosis that you make on the bedside when you have a patient presenting with bilateral, symmetrical, inflammatory polyarthritis involving the small joints of the hand and the feet, and a duration usually in excess of 6 weeks. This in early arthritis has come in for revision, but it's a fairly robust definition. 6 weeks allows you to segregate the self-limited viral arthritis. It's not sacrosanct, but it is a definition which has stood the test of time. And the boggy swelling of rheumatoid is remarkably distinct from the bony swelling that you get with osteoarthritis. So examination of the hands is what you require actually to diagnose rheumatoid arthritis with only a modicum of investigations. Rheumatoid arthritis and rheumatoid factor can exist independent of one another. Nearly 20% of your patients with rheumatoid arthritis are going to be seronegative, and the only way to make that diagnosis is clinical examination. Conversely, you could have several situations where you have rheumatoid factor positivity and the patient does not have rheumatoid arthritis. So this is an iteration of the well-known fact that you can have seronegative rheumatoid arthritis, and conversely, the mere presence of rheumatoid factor does not mean rheumatoid arthritis. And this is an example of a young man presented with right wrist pain, was started on low-dose corticosteroids, hydroxychloroquine did not improve. This is his X-ray. You can notice some carpal crowding here, and this is a biopsy that was obtained from the wrist, necrotizing granulomas, and this is tuberculosis of the wrist mimicking rheumatoid arthritis. And where the referring physician went wrong was that this patient was RF positive, and he thought that this patient has joint pains with rheumatoid factor positivity. He thought it's a straight case of rheumatoid arthritis, which brings us to several caveats. One should be very reluctant to diagnose rheumatoid arthritis in a patient with single joint involvement, as in this young male. By definition, it's a polyarticular disease. Give it time, and what ostensibly appears as a single joint involvement would become polyarticular. Sometimes exceptions prove the rule. And then one should be very reluctant of entertaining a diagnosis of rheumatoid unless hands are affected. There's only one exception. If the patient has taken corticosteroids, then it actually masks the clinical picture. DIP joint involvement, uncommon in rheumatoid arthritis. Low back pain due to rheumatoid, again, that's not common. The only part of the spine that gets affected is the cervical spine. And last but not the least, asymmetrical involvement, you need to think in terms of psoriatic arthritis. So we've talked about causes of hand pain, and we are talking about arthritis that afflict the hand. We've talked about nodular osteoarthritis, osteoarthritis of the thumb, rheumatoid arthritis, and now we talk about psoriatic arthritis. The phenotype of psoriatic arthritis is extremely varied. You can have symmetrical involvement, actually indistinguishable from rheumatoid arthritis, and several of these patients who get a label of seronegative rheumatoid 5 years down the line may come up with a patch of psoriasis and you revise your label. could have asymmetrical involvement, DIP dominant disease, arthritis mutilans, or spinal involvement. And psoriatic arthritis is also multidimensional. You have the domains of the nails, the skin, the scalp, and as I said, spinal involvement, particularly neck involvement, is fairly common with psoriatic arthritis. And then the skin psoriasis could be in the hidden areas. The patient may not volunteer a history of psoriasis, may not link the two together. So you learn with time to ask about history of skin lesions, and this is a giveaway. Clinical examination. This is the fusiform swelling of rheumatoid arthritis, plump in the middle, slender at the extremities, and in contradistinction what you have is the sausage digit or a cylindrical swelling of psoriasis. And if you learn to look at the toes, sometimes you get a toe which is a classical sausage toe, and you can then make a diagnosis. And this is arthritis mutilans, fortunately becoming rare in clinical practice today. And these are more examples. And as you can appreciate the nail changes of psoriasis, you have this thumb, and this thumb is a giveaway that this patient is having psoriatic arthritis. Now, gout. Gout traditionally is a disease that afflicts the lower limbs. Preferential involvement of the joints of the lower limb, but polyarticular gout in the elderly is not uncommon. And as people live longer, what we are encountering is gout in the elderly, where the gender distinction gets blurred. The upper limbs can be affected. Of course, if you have tophi like this, you actually don't need any other investigations, but at times it could be more subtle. You could have midfoot involvement, hindfoot involvement, classical podagra may not be there, and uric acid may be normal when you order that test, especially during an acute attack. But if you are used to looking at X-rays, this is classical. And what you can appreciate is an erosion, bone density is preserved. This may have overhanging edges, may have a soft tissue component, can be away from the joint, and there is relative preservation of the cartilage, and these are points which help you to distinguish this from rheumatoid arthritis. And of course, while we talk about hand arthritis and we talk about nodules, we have several conditions that can give rise to hand pain with nodules, and these are some examples. This is a classical rheumatoid nodule. This is a gouty tophus, and at times the distinction can be difficult and you need to do a crystal analysis. And this is an uncommon condition which all rheumatologists occasionally come across, multicentric reticulohistiocytosis, and this is one example. So when we talk about arthritis, and having talked about crystal arthritis, I actually did not have a picture of CPPD that I could show to you. We move over to connective tissue diseases, and with connective tissue diseases, the commonest that we see in clinical practice is Sjogren's, but the symptomatology of lupus at times can be very dramatic. This is the smorgasbord of lupus, multisystem disease. So if you have a patient who presents with inflammatory polyarthritis with the added features of fever, photodistributed rash, hair loss, you need to think of lupus. Actually, the arthritis may be indistinguishable. Some of these people have rheumatoid factor positivity, a fair number, and they get a label of rheumatoid arthritis. And this is also what happens with Sjogren's. And this is the Jacquard's arthritis, correctable deformities, and lupus today has replaced rheumatic fever as the #1 cause of Jacquard's arthritis. Scleroderma, the skin changes are a giveaway. And the arthritides mimic rheumatoid arthritis. You also have Raynaud's phenomena. And this is classical sclerodactyly. Uncommon causes. This is a strapping young gentleman I saw, had constitutional symptoms, upper airway symptoms, GPA of Wegener's, and the X-ray is classical. And then, of course, this is a dactylitis and ulcerative colitis. So you have common conditions, uncommon conditions, and apart from arthritides, we have soft tissue rheumatism, and this is an example of de Quervain stenosynovitis. You need to actually move the hand in two directions to realize, and when you move it in this plane, it provokes pain, and this is de Quervain's. And then you have Dupuytren's contracture as a cause, and then you have ganglion cysts. So you can have multiple reasons for hand pain, and in long-standing diabetics, we can have diabetic chiroarthropathy. Uncommon causes, well, we've talked about some common causes. Sarcoidosis, tuberculous dactylitis in our country, CPPD, Hansen's disease, adult Still's disease, hemochromatosis, and this is an example of osseous sarcoid. I have only put up cases where these were patients that I had encountered. I actually do not have a patient photograph of hemochromatosis, but this is the list of hand causes of hand pain. And I would like to conclude by mentioning that the approach is overwhelmingly clinical. You need a modicum of investigations, patient anamnesis, and a careful physical examination, and you have the diagnosis of hand pain. Thank you very much for your kind attention. And if this has whetted your appetite in clinical rheumatology, these are our two offerings. Thank you very much.
Thank you, sir.